The clinical manifestations of TLS can include the development of fluid overload from the renal failure. This can result in congestive heart failure. The specific electrolyte abnormalities can lead to cardiac arrhythmias and lead to hypotension. The inflammatory components can affect all portions of the body, and the accumulation of these byproducts can lead potentially to seizures. So the pathophysiology is that when there is the breakdown of the cancer cells, it releases a large amount of contents. And so the breakdown can occur by a number of mechanisms depending upon what type of chemotherapy is used. But if we talk about traditional chemotherapy, such as the use of adriamycin or cyclophosphamide, the cells, what are referred to as apoptose, and their contents are spilled out, including calcium and phosphate and the potassium. But also there is a breakdown of nucleic acids, and particularly purine nucleic acids. And those, normally the body would convert those, go to a process where they are converted first to xanthine, and xanthine's converted to uric acid. However, what happens in tumor lysis syndrome is the homeostatic mechanisms that would generally take care of all this, and what happens on a daily basis in our body, gets overwhelmed. And so there is a large accumulation of uric acid, and that uric acid generally is cleared in the kidneys. So what happens is that if the kidneys start to malfunction, you're not clearing it, actually the uric acid starts to concentrate. And when it starts to concentrate, then it starts to crystallize, and it actually forms crystals within the kidneys, which leads to renal failure. People try to reverse this process by alkalizing the urine. And when you alkalize the urine, you start to have formation of calcium phosphate crystals. And when those calcium phosphate crystals start to form, or there's this product, calcium phosphate, you actually start to see clinical hypocalcemia. And the hypocalcemia leads to tetany, and it leads to heart arrhythmias, and then can lead to seizures.
In terms of the biochemical changes associated with TLS, there's sort of a classic 4 or 5 things that we think about. Hyperkalemia, or an elevated phosphate, elevated creatinine, which is related to renal dysfunction, hypocalcemia, which often co-occurs with elevated phosphate, related to calcium phosphate deposition in organs. The clinical manifestations of TLS are the individual clinical manifestations of those electrolyte abnormalities. So for example, probably the most dangerous is actually hyperkalemia. The higher the potassium level, the higher the risk of developing cardiac instability, both atrial and ventricular arrhythmias, which can be life-threatening. Hyperuricemia can lead to deposition of uric acid within the kidney, within the renal tubule system, which can lead to renal dysfunction. Kidney dysfunction can then subsequently lead to electrolyte abnormalities, and so that loop can feed on itself. Hyperphosphatemia with concomitant hypocalcemia can lead to deposition of calcium phosphate crystals in organs like the kidney, but also in other organs, leading to vascular instability or kidney dysfunction or other organ dysfunction, depending on where that crystallization can occur. And hypocalcemia by itself can lead to neurological complications. And so taken together, you can have instability in the kidney, heart, neurological system, which is why TLS, if left completely unchecked, may be life-threatening. Fortunately, we know the diseases that are likely to lead to TLS, and so we're very aggressive about our monitoring and prophylaxis strategies. So if we see an elevated potassium, we can address that. If we see an elevated uric acid, we can address that. So seeing clinical TLS is a rare complication, but that's because we're using all of the different strategies that we've discussed in order to mitigate that risk. So at most, we're seeing laboratory TLS.